We are
Good
waiting
evening,
for
sir.
it.
Good evening, Rajan sir.
Good evening, sir.
Good evening, sir. Good evening, Rajan, sir.
Rajan sir, എല്ലാവരും ഉണ്ടല്ലോ. Good evening.
Good evening, Rajan.
Good evening. Babu sir.
And without losing time, I will start our program, sir.
Okay.
So I
We'll start, sir.
welcome our outside chief guest from the Karnataka, that is none other than Dr. Freedom, but I welcome, sir. He
Thank
is the
you,
author
sir.
of,
Thank you.
author of 2 books that is SR famous among the students, SRB, Clinical Methods and Theory. And I got all the volumes except this year at the free of cost. Thank you for your sending the books
Sir.
to me.
Thank you,
That
sir.
is
Thank you,
very-
sir. Thank you, sir. Thank you, sir.
And welcome, sir, once more. And Captain, sir, is the former HOD of Trivandrum Medical College and this year Cicera Award winner of ASA for the best teacher. And now we go to Dr. T.A. Vasu, sir, who is the retired professor from Trivandrum Medical College, now working in Assisian Medical College as professor of surgery. And Vishwanathan is the unit chief of Government Medical Trivandrum. And welcome all these today's examiners, and I also welcome our great teachers and great orator and surgeon Diane sir, former HOD of Calicut Medical College, and Dan Bose sir, former HOD of Calicut Kottayam Medical College, now working at Sri Govind Medical as Dean of the institution. I also welcome the today's VIP, that is Sneha Raveendran, DND student, BMH student, and BMH Baby Memorial Hospital, Calicut. And also I welcome all my faculties and my other students. And also I welcome, I think, Professor Cancer is here. I also welcome the Professor for this program. And once more, welcome you all. And we'll proceed the programs. I'm inviting Sneha Raveendra to start the program. The presentation, not the program, presentation. Sneha, come on.
Okay, sir.
Vasil Marika sir is also there, Govi.
Sir, Professor Malkar also there. I especially inviting our senior
Thank you,
member
sir.
of our. Okay.
Good evening, sir. Let me share the screen, sir.
Yes.
Hello, sir.
Yes. But you are audible.
Okay, sir.
You can start.
Okay, sir. Today I'm going to discuss about a case of obstructive jaundice. Here I'm presenting case of 61-year-old female who is coming from Kannur. She is a housewife, presented with yellowish discoloration of eyes for the last 1.5 months, dark colored urine for the last 1.5 months, and generalized itching for the last 1 month. Coming to the history of presenting illness, the patient was apparently normal 1.5 months back. Then she developed yellowish discoloration of eyes and dark colored urine, which gradually get deepened along with the discoloration of skin and pale colored stools. She also complains of itching all over the body for the last 1 month. Initially, it was mild and occasional, then gradually progressed and become more intense, especially during the night, and that disturbed her sleep. For the last 1 week, she noticed a mild decrease in the intensity of discoloration of her urine. And she also gave a history of melena associated with it. She is having feeling of tiredness, nausea, loss of appetite, and loss of weight. She was 65 kg initially, and now she is 59 kg. There is a loss of 60 kgs in 1.5 months. 6 kgs. There is There is no history of abdominal pain, fever, vomiting, no history of altered sensorium, abdominal distension. There is no history of joint pain, skin rashes, or no history of food intake from outside, no history of IV drug abuse, and there is no history of blood transfusion, no history of cough, hemoptysis, bone pain, seizures. Past history. She has a known case of type 2 diabetes for the last 20 years and is controlled with oral hypoglycemic agents and insulin. She is also a known case of bronchial asthma, needs occasional medications. History of hysterectomy 9 years ago for abnormal uterine bleeding. Coming to the personal history, she consumes vegetarian diet, bowel and bladder habits normal, sleep disturbed as mentioned earlier, no addictions. Marital and obstetric history, married 40 years ago, non-consanguineous marriage, and her husband died due to CA pancreas and has 2 children. They are healthy. Family history, she has 3 siblings. Her elder sister died of CA pancreas at 65 years. The parents died due to natural causes. Summarizing the history, this is a elderly 61-year-old lady who's a known case of type 2 diabetes, presented with a painless progressive jaundice with a recent history of decreasing urine discoloration and is associated with itching, generalized tiredness,
That's all.
appetite and loss of weight, and disturbance in sleep. Hello.
Sneha, some problem with your audio. Hello.
Hello. Am I audible, sir?
Now it's audible.
Audible in between it appears there's a mixing going on there.
Yes.
Now you are audible.
Yeah, you're audible. Please.
Proceed.
Let me proceed to examination, sir.
Before going to examination, I will go to examination. Captain, sir, what about her history and satisfied with the history?
What about the stool you have told? You asked anything about the stool, Sneha?
Yes,
Only
sir. Pale colored stool, sir.
how many times she's having a stool and any specific things she has told?
Sir?
You told another thing. You told family history. Sister had.
Yeah,
Whether
sister
her
had.
earlier generations anybody had such
No,
similar
sir.
disease? Have you asked?
Yes, sir. Her parents died due to natural causes. There is no other history from the family, sir.
The jaundice never been waxing and waning or any time decreased in intensity. She is clear about that.
She was saying that for the last 1 week, there is a decrease in
It's
the
progressive.
discoloration.
Sir, Karthikeyan, sir.
Captain, sir. Captain, sir.
So with the history, next is which system you are going to examine. So there is a history of melena, there is a history of pale colored stool, and in between, you said that there is decrease in jaundice also. Okay.
Gastrointestinal systems.
Okay, proceed.
And other Vasu sir and this Vishwanathan. Hello.
Sir, I have a question to ask Sneha. You were mentioning about in the history, you have not mentioned about any pets in the home or any contact with any animal. Is it important? Is it relevant when there's a case of jaundice? This is not a long history. This is 1.5 months history. And you said it is a painless progressive jaundice, and then you are suddenly saying that it is decreasing jaundice also. So, but it's not a very long history to say both. Whether we have to see more cycles to say know whether it is waxing and waning type of jaundice or it is a progressive jaundice. Anyway, you asked for there is melena and jaundice, right? So in
Yes,
the
sir.
history there is melena and jaundice. So what additional points do you ask in history when there is melena and jaundice, and when there's a short duration of obstructive jaundice? What are the other things that you should ask for? Melena and jaundice, what are the associations?
If there is bleeding, gastrointestinal bleeding, there will be melena.
Yes. Upper
Then,
GA bleeding, right? There should be upper GA bleeding, which means it could be either from the periampullary region or something above that also,
Yes, sir.
right? And
Yes.
what could be the causes? So we'll discuss the causes later in obstructive jaundice, the situation where melena comes. Anyway, that is one point that you should have asked a detail more in history, and also regarding any pets. What is the relevance of pets here?
Because of the liver flukes.
Just liver flukes or any other?
Liver flukes in China.
Can you have jaundice from something compression from outside, some large cyst?
Tuberculosis.
Pets and tuberculosis.
Lymph nodes.
Jaundice.
Any cystic swellings in the liver due to pets?
Hydrated.
Yes, hydatitis is one of the commonest things, right? Okay, go ahead.
Was there anything you
She has summarized everything very well, and I wish to say one comment on the slides. If you are presenting in a stadium, not in this case it is not a problem, but if you are presenting in a stadium, there should be only 6 lines in a slide. We'll take care of it. And one more thing is that a comma, a word is followed by a comma followed by space, then the word, not continuous. And another thing is that melena is the commonest word which is spelled by all the medical students and even doctors. M-E, not M-A. Thank you. Proceed.
Okay. Proceed. Sneha.
Okay, sir. Coming to the physical examination. Patient examined in daylight after obtaining verbal consent and adequate exposure and privacy. General examination. Patient is conscious and cooperative, well oriented to time, place, and person. She is moderately built and nourished with a BMI of 23 kg per meter square and Karnofsky performance status of 80, well hydrated, pulse rate is 66 per minute, regular in rhythm, normal volume, and character of the vessel was normal, no radio-radial or radio-femoral delay, BP 120/70 millimeter of mercury, measured in right upper arm in supine position, respiratory rate 18 per minute, thoraco-abdominal, and she is afebrile. And there is icterus present. Pallor could not be appreciated.
Okay.
Hand yellowish discoloration of skin present, scratch marks present all over the body.
Yes. Occasionally, you are not
Oral cavity, left palate, no stigmata of liver failure. Hello, sir.
Occasionally, you are not audible. Some problem with your.
I want to repeat.
In the general examination, I think You can repeat. That the itch marking onwards. Itching mark.
Hello.
You can repeat the
Hello?
general examination examination of skin and nails. Not audible. Okay, you can continue.
General exam.
From this step onwards, you can continue.
General examination. (23 kilogram per meter square). Karnofsky performance status of 80, and she is well hydrated. Pulse rate 60.
Sneha, that is over. Come on. Next. Occasionally, we are missing
Head
you.
to foot.
That is why.
Head to foot examination, sir.
Okay.
Head to foot examination. Yellowish discoloration of skin present. Scratch marks present all over the body. Oral cavity. Good oral hygiene. Yellowish tinge of tongue and soft palate. No stigmata of liver failure. Coming to the abdominal examination. Inspection. Shape of the abdomen is normal. Umbilicus central in position and inverted. All quadrants move equally with respiration. Skin over the abdomen. Scratch marks present. Scar of fan and steel incision present. No visible peristalsis, pulsation, no engorged veins, flanks free, no visible swelling on inspection. Hernial orifices normal, external genitalia normal. Coming to the palpation, no local rise of temperature or tenderness, abdomen soft, a globular swelling of size around 5 cross 5 centimeter, palpable, predominantly in the right hypochondrium, extending to right lumbar region with regular, well-defined margins. Inferior, medial, and lateral margins are palpable. Inferior margin extends from 5 centimeter from the costal margin. Medial margin extends 4 centimeter from the midline, and lateral margin is palpable at 9 centimeter from the midline. Superior margin merges with the liver margin. Surface of the swelling is smooth, soft in consistency, moves with respiration. Head raising test, the swelling reduces in size. Liver is palpable, 2 finger breadth below the right costal margin at right hypochondrium and extending to epigastrium and to the right lumbar region. And the regular liver is palpable, right costal margin at the right hypochondrium and epigastrium, regular, sharp margin, smooth surface, firm in consistency. No splenomegaly, renal angle is normal, hernial orifices and external genitalia normal. Coming to the percussion. Upper border of liver dullness felt at 5th intercostal space at mid-clavicular line. Liver span is 18 centimeter. Abdomen is resonant on percussion except for the mass, which is dull on percussion and is continuous with the liver dullness. There is no shifting dullness. Auscultation, vowel sounds present, no bruit. On rectal examination, perianal skin is normal, sphincter tone is normal, no mass or deposits felt, and is empty on examination. Per vaginal examination is normal, no left supraclavicular lymph node enlargement, no spine tenderness. Other system, respiratory system, air entry bilaterally equal, no added sounds, CVS is S1 to head, no murmur, CNS, higher mental functions normal, tone and power of both upper limb and lower limb, bilateral normal, no focal neurological deficit.
Summary.
Into the summary. 61-year-old female who is a known case of type 2 diabetes presented with painless progressive jaundice with a recent history of decrease in intensity of jaundice, which was associated with itching, loss of appetite, and loss of weight, and melena. with a family history of carcinoma pancreas. On examination, she is icteric with a hepatomegaly and palpable intra-abdominal mass, likely to be gallbladder. My provisional diagnosis is obstructive jaundice due to malignant etiology. Was probably periambulary carcinoma. And second diagnosis is PA head of the pancreas and distal cholangiocarcinoma.
Okay, now we'll go to examiners. But sir, Sriram Bhatt sir.
Yes, sir. This liver you said firm, Neha. Is it
Yes,
soft or firm?
Firm, sir.
You said gallbladder is, what is the size of the gallbladder you said?
5 cross 5 centimeters, sir.
Okay. Why percussion? You have percussion over the gallbladder?
Yes,
Percussion
sir.
note over the gallbladder. What is the percussion note?
It was dull on percussion, sir.
There is no free fluid.
No free fluid,
Have
sir.
you looked for a right side pleural effusion?
Yes, sir.
You have just mentioned respiratory system normal. Whether there is effusion present or not, you have to specifically look for actually.
Okay, sir.
Okay, scratch marks. Okay, you have mentioned scratch marks. Free fluid not there, you said.
No free fluid, sir.
Spleen, you have looked for spleen.
Yes, sir. No splenomegaly.
Splenomegaly is SP single E actually. SPLENO. Splenomegaly it is, not splenomegaly. Spleen is SPLEEN, but splenomegaly.
Okay,
Double,
sir.
like Dr. Vasu sir told, Dr. Belling mistake is absolutely right actually. It is splenomegaly, not splenomegaly. Spleen, splenomegaly. Understood the spelling difference. Okay.
Okay. Okay, sir.
Thanks. You said periampullary, why only, you said initially you said there is no waxing and waning. Then Professor Vishwanath asked, no, then you said that there is waxing and waning. You had a real confusion about that. That time he asked, what else you will, detailed history of
Sir,
stool is important. That's what he has really highlighted properly.
there is only a short history, sir. Only the last one. For the last 1 week, she gives a history of decrease in the discoloration.
Decrease in the history. Okay. And why? How will you correlate family history for your diagnosis? You said there is a family history. Every slide you have put that family history.
Sir.
Family history is relevant for which type? Out of 3.
Family history, PDAC, sir. Pancreatic ductal adenocarcinoma, sir.
Okay. Sir, Karthikeyan sir, Rajan sir.
By the host, okay. Now unmuted. Oh, right, Neha. Yes, you are presented nicely. So, as you said, I was also noting the spelling mistake. So you should be very careful when Dr. Vasu and Dr. Pasimarika sir is there about the spelling mistake and the commas and all. So they are very particular. Okay, a PG like you should not make mistakes like that. These spelling mistakes. Okay, right. So you said exactly all the clinical picture. Clinical picture is suggestive of a periambulary carcinoma or C-head of pancreas. Of which one you prefer most?
As there is a reduction for the last 1 week and there is a history of melena, sir, I prefer periambulary carcinoma.
Okay, good. You said there is no stigmata of liver failure. What are the points you look for any liver failure clinically?
Liver failure from head to foot, there will be loss of hair, icterus, parotid enlargement, and spironavy, Dupuytren's contracture, palmar erythema, gynecomastia in males, and testicular atrophy in males, ascites, fetal edema.
Okay, right now. So with this patient gives a history of 1.5 months duration, is it? And with that, in that period, do you expect any waxing and weaning?
Usually no, sir. Usually it is seen in long duration.
Okay, agreed. Anyway, you are right because there is a short history, but there is a history of melena, probably due to what? Melena is due to?
Most probably due to sloughing out of the periambulary neoplasms.
Just a small bleed from the periambulary. A small bleed can cause this melena, and also that may be the reason for a decrease in the jaundice also, is it?
Yes, sir.
Okay, now Dr. Vasu.
Rasu, hello.
Vasu
Rajan,
sir,
okay. Rajan sir have raised a question why she has not mentioned about any bleeding tendency nor looked into for ecchymosis. What you have to say?
No
What is
rashes, sir.
the importance of that?
PET-K will be there, sir, because of the derangement of the coagulation.
Yes.
PTINR will be raised.
Okay. So you have to say whether it is present or not. Ecchymosis and bleeding tendency.
Okay, sir.
Okay. Then this is even though we say this type of malignant jaundice are painless in the books we say painless, but there may be minimal pain for most of the patients, a dull aching pain for almost all these the so-called painless jaundices. In this patient is absolutely no pain. You are sure?
Yes, sir. There was,
Okay.
she doesn't give a history of pain.
Okay. Good.
Yes. Vishwanathan.
Yes, sir. So a couple of questions to Dr. Sneha. One is like the liver span is 18 centimeters, right? You mentioned
Yes.
it 18 centimeters. Where did
Yes.
you measure the liver span?
Sir, while starting the percussion from the second intercostal space.
No, this is at which point? This is at which point? Which
Mid-clavicular. At mid-clavicular line, sir.
you mentioned that?
I have mentioned in percussion, starting
In detail?
from percussed in mid-clavicular line.
Okay. What is the normal liver span in mid-clavicular line? Is liver uniformly having the same span all around, all the way?
No, sir. No, sir.
At mid-clavicular line, what is the normal liver span?
It is 12 to 14 centimeters.
Okay. What about the midline? When you come to the substernal level?
It is only 2 to 3 centimeters.
3 centimeters. 6 to 9 centimeters. Anyway, so the liver span you have to mention where you are measuring the span. And if it is 18 centimeters, what does it signify?
There is hepatomegaly, sir.
Then why didn't you get a hepatomegaly? And Sriram sir was asking a very pertinent question. There was whether there was pleural effusion on the right side. Why? You get an apparent increase in the liver span. Pleural collections, subdiaphragmatic collections, toast liver. These are some conditions where you can get an apparently
enlarged. Okay, palpable.
Yes. So that is why Sriram sir asked whether you mentioned for pleural effusion. Okay.
Okay, sir.
And also in infective conditions, there is some subpleural collection, no subdiaphragmatic collection. It can again push the liver down, and the entire dullness may be appreciated. Okay.
Okay, okay, sir.
Okay. So, sir.
Hello, sir. Over.
Sir.
Hello.
Somebody.
Sneha, this patient got any itching on the face? This patient got any itching on the face?
No, sir. No itching on the face.
You mentioned the itching all over the body. In a classical obstructive jaundice, what are the sites you have the itching?
Usually on the extensor surface.
Extensor well, upper limb and lower abdomen. And
abdomen.
You mentioned the extremities examination. Did you look for any ulcer, chronic non-healing ulcer in the legs?
No, non-healing ulcer, sir.
If the jaundice and non-healing ulcer, what indicates?
It's hemolytic anemia, sir. Hereditary spherocytosis, sickle cell anemia.
Okay. In the palpation also, you didn't mention anything about the umbilicus. Did you palpate the umbilicus? Only inspection.
Yes, sir.
Palpate?
Sir, umbilicus was normal.
You mentioned normal in palpation. Did you palpate?
Yes, sir.
What is the reason for palpation umbilicus? Especially look for what?
System area nodules, sir. Any metastasis?
How the metastasis method of reaching the umbilicus? In what way?
Through the ligamentum teres.
One method ligament teres, other technique, other method.
The pattern.
One is the
Umbilical vein.
bloodstream also. Other is the directly from the ligament teres. Okay.
Right.
Now we'll go to the examiners and Sriram sir, what's up?
Yes, sir.
Okay, you can start now.
Yes, sir. Examination. You said liver is firm. How will correlate this one, Sneha? Usually, liver will be in such situation soft or firm. How will correlate? Why it is firm? Why liver is enlarged in this patient?
Because of the hydrohepatosis, sir.
Yeah, but hydrohepatosis liver is usually
Soft.
soft, no? So how are you sure about your finding? If it is not so, you have to explain why it is firm. Whether there is any nodularity?
No nodularity, sir.
Nodularity. If there is nodularity, what it means?
There will be associated cirrhosis or metastasis.
Okay. What is the fecal color you said?
Fecal color was pale. She was describing as
What's the
pale,
normal fecal color?
yellowish, sir.
Why it is so?
Yellowish is due to presence of stercobilin in stool, sir.
So what happens in obstructive jaundice?
In obstructive jaundice, the bilirubin won't reaches to the intestine.
Okay, so stercobilin will be
Sterco will
absent.
be absent.
Okay, that you have asked. What is silvery stool? Have you heard about that?
Yes, sir.
Where
That
will
is
get it?
in obstructive jaundice. If it is mixed with blood, sir. In case of melena, sir.
Okay. So you said periampullary carcinoma and CA development. In that you are telling short duration. So we are thinking periampullary carcinoma is set. Which is better as far as patient point and as far as surgeon point?
It is periambulary, sir.
Okay. Sir, we'll go ahead with the investigation, or you want still continuing the clinical examination? Sir?
Little more clinical examination.
Okay. Karthikeyan, sir.
So I think the clinical examination, Neha has completed the clinical examination. Now she has to confirm the diagnosis. She said it could be a periambulary carcinoma, it's a surgical jaundice, or obstructive jaundice. Now, how will you confirm your diagnosis? We will go for investigations, is it?
Okay,
Any
sir.
others?
Sir, I want to do a set of investigation to confirm my diagnosis and to assess my patient and to rule out the metastasis, sir. And hello, sir.
Yes.
Yes, we can continue.
Go on.
Sir.
Go on with the investigations.
Okay, from I have to order for a complete hemogram to rule out anemia and to know the total count of the patient and liver function test.
In between, Sneha, I'm going to interrupt because Rajan sir made a comment that you have done a PV and you said it's normal patient underwent hysterectomy. Will you find anything? PV?
Sir, only the vaginal part I can palpate, sir. The vault.
Usually you can feel the fundus, is it right? Not very sure.
Service.
Okay. At the end, Rajan sir will answer. Okay, carry on. Carry on, Sneha.
Okay, sir. Then, sir, PTINR to know the coagulation profile. Then have to go to the imaging, sir.
The blood, before the imaging, you are mentioned the blood examination. It's obstructive jaundice. What else you examine the blood?
In liver function test, sir, the direct bilirubin will be raised and the alkaline phosphatase will be raised. Then Then in
a obstructive jaundice, how much can raise obstructive jaundice?
in obstructive jaundice can raise
You still
up
raise.
to 30. Up to 30, sir.
And enzymes. Yes. Will you do any enzyme study?
Alkaline phosphatase, how much?
Also ask some question. Not clear, sir.
Hello.
I was explaining
Not
your
clear.
question. How much? I was explaining your question. How much alkaline phosphatase? That was I was asking. How much? Why? What is the normal value?
Alkaline phosphate, sir.
Ah.
It is 120.
What unit? Mention the unit.
No, physiological value is fixed.
Sir, I can't hear you, sir.
No, physiological value is fixed. You said 120. So 121 is abnormal, 119 is abnormal.
40 to 140, sir, range.
You should range as well as the units in mentioning on the enzyme.
In the international unit per liter.
What are other countries alkaline phosphate can raise? Only is obstructive jaundice.
In it is bone tumors, sir.
How do you differentiate bone tumors or from the obstructive jaundice?
There will be calcium. There will be derangement in calcium and phosphorus in bone tumors.
Yes. After the blood examination, that's all your LFT liver function. That's all you. Please mention the important liver function test.
Then the protein hypoproteinemia will be there. Serum albumin will be low, sir. Then 5' nucleotidase can also get elevated. Then
why serum albumin is low in obstructive jaundice?
Because liver derangement in hepatic functions, are liver is synthesizing.
Albumin is only synthesized in the liver. Okay. Yes. Other investments. Okay. Then what else? You can proceed.
Then PTINR will be deranged, sir.
You already mentioned.
Then moving to imaging.
Diagnosis.
Tumor markers can be done, sir. CA99 will be elevated. Then
CA19 elevated in obstructive jaundice. What do you watch? Your diagnosis periambulary carcinoma or CA endopancreas. What obstruction CA19 will be raised?
CA99 is raised in all the obstructive jaundice, sir. Cholangiocarcinoma.
You mentioned. Yes. Kapil sir, you can proceed. Kapil sir.
Neha, to say it is due to malignancy, what should be the level of the bilirubin? By just looking at the bilirubin level, you can say this could be an obstructive jaundice or this could be malignancy.
The bilirubin will be more than 15.
Correct. You're right. You are right. Then what about alkaline phosphatase? Bilirubin should be more than 15. Alkaline phosphatase?
Alkaline phosphatase should be more than 500.
Right. You are right. More than 500 international units per liter. Okay. Right. Then there will be SGOT and SGPT. Enzymes.
SGOT and SGPT need not be raised in the case of obstructive jaundice, but if it affects the hepatocellular function, it will get raised, sir.
Usually it will be 10 times than normal, is it?
Yes, sir.
What about the other SRB? Am I right?
Yes, sir. Yes, sir.
Yes.
Okay. Go on with the other investigations as imaging modalities, right?
Start with the imaging, Sneha.
First, as an extension of my clinical examination, I will opt for ultrasound, sir.
Okay.
To look for the exact cause of the obstruction and the level of obstruction, and about the ducts, biliary radicals, and pancreatic ducts. And if a lesion is visible, then its extension to the vessels, and to look for ascites.
No, not like that, Sneha. Ultrasound is a screening method for all abdomen conditions currently. It is rather an extension of clinical method. You don't be able to get a detailed view of the biliary system by ultrasound. You will have a gross idea. Then eventually you step up with the further imaging for detailed findings actually. Okay. You won't be able to get a minute details of the biliary system by ultrasound. Okay. But it is the initial screening method, absolutely accepted. It is the extension of clinical method now. Definitely, every abdominal pain, abdominal condition, ultrasound is a must to initially to guide you to have a further imaging method, and so that what you want to look for in eventual imaging, what you are going to do. So, what next imaging you are going to do?
CCT abdomen, sir.
Okay, here what all things you look for?
Here, the exact cause of the obstruction, and the level of the obstruction.
Okay.
And the morphology of the lesion, and the status of the major vessels like portal vein, superior mesenteric, and the celiac axis, and hepatic artery.
Okay.
Then the ascites, and the peritoneal and liver mets.
Okay, liver mets, yes, peritoneal mets. Sensitivity is not much actually.
Less, sir.
For the CT.
Okay.
Okay.
Then lymph node status.
Okay.
Sneha, in the USC, I want to mention what specifically look in this case, your case, what you are expecting.
You can always mention endosonography. That is more relevant. That's a specific imaging. Screening, ultrasound is a screening method. Endosonography is very, very useful.
Yes, sir. Yes, sir.
And you can always see the portal vein very nicely.
In your case, what is the expecting the ultrasound? In this case,
ultrasound, there will be biliary radical dilatation can be seen able to see, sir.
Usually look at the CBD, lesion, gallbladder.
Intrahepatic biliary, IHBR.
Intrahepatic. Yes, sir. Intrahepatic radicals. Okay. Yes. Then what investigation will do?
You said endosonography. Then the role of MRI, Sneha, here.
MRI, we can get a better delineation of the intraluminal, sir, lumen, regarding the lumen, sir, MRCP.
Lumens, biliary radicals, and CBD. That will be on lumen. Okay.
Yes, sir.
Sneha, what is the dye in MRCP? Any contrast? Any contrast used?
No contrast is required, sir.
MRCP is a non-contrast, but non-invasive. But MRI, they will use contrast. What in contrast, sir, is asking?
Gadolinium.
Okay. True. No problem.
Any complication, gadolinium? Can gadolinium produce any complication?
I'm sorry, sir.
Gadolinium induces the nephropathy, renal failure.
Yes, sir.
Okay. So you,
Creatinine, have you specifically looked for creatinine in this patient, Neha?
Yes, sir.
What is the reason?
Because one reason we have to take contrast enhanced CT, and other reason there will be a hepatorenal syndrome, sir.
What are the causes for hepatorenal syndrome?
Because of the dehydration and the bile salts deposition in renal tubules.
Bile salt deposition in the renal tubules. Okay. And toxins itself, because toxins will be there. Toxins itself can cause the stone. Other than bile salts plugging the renal tubules. Okay.
Yes, sir.
It's also considered transient bacteremia. It is one cause for your syndrome. other things. Yes.
Okay, sir.
Okay, Sneha, we'll go by an order, is it? What about an X-ray abdomen? Is it indicated? Base level
Yes.
investigation?
Yes, sir. To rule out metastasis in lungs.
Ah.
Um,
Abdomen? Don't see any growth, but definitely
if there is obstruction.
any calculi in the pancreas or in the gallbladder, you can visualize, is it?
Okay.
Base. Definitely to rule out. Definitely you have to rule out one by one like that. Next is what about a barium meal? You advise a barium meal now? Because nowadays definitely we will advise a barium meal. You should know, even though you don't advise, definitely you should know what is the inference in a barium meal X-ray.
In a barium meal,
What sir is asking is, if you do a barium meal, what will be the finding in the periampullary carcinoma? What will be finding in carcinoma head of the pancreas? At least 30 years back, when nothing was available, when we are postgraduate 35 years back, that will be a very relevant finding which we used to look for. At least our professors used to look for. That is what sir is asking.
there will be a widening of C loop, sir, in case of pancreatic adenocarcinoma.
Okay.
And there will be a reverse 3 sign
In what country is reverse 3 sign?
in case of periambulary.
Okay.
What is the name for that widening of C loop? What is the name for that?
What it is called? What sign it is called as?
C, P, C,
Start with the
C,
P.
pad,
Okay. Pad sign.
pad sign.
Bad sign.
So since you asked, sir, I will ask one more question, because what is the percentage of barium sulfate used for barium meal?
I don't know.
Traditional barium sulfate is used or micro barium sulfate is used? What is a micro barium sulfate? Have you heard about that? Have you seen anybody doing barium sulfate? Have gone into the radiology department and seen how exactly it is being done barium? Occasionally we send the patient for certain specific indications. Even now we send for the barium study specifically. Certain situations still you may have to ask. In such situation they use microbarium sulfate. Now they never use barium sulfate currently. Understood?
Yeah.
No. So what is microbarium sulfate? If you go to the radiology department, they will tell you. Look at that. Look at the difference with the traditional barium sulfate, which is not used now. Now always we use microbarium sulfate, microcrystallizer barium sulfate. You don't get precipitated. It prevents precipitation. So blockage won't be there. Your usage will be more handy when you use the microbarium sulfate. Okay. You walk into the radiology department in your hospital, you can see. You can ask them. They will show. It comes in a packet actually. Okay.
Okay.
Okay, then because to improve your general knowledge, I am telling you that barium sulfate 75% for base and 50% for meal and 25% for enema. Is it? That's what we used. Okay, just to improve your general knowledge. Okay, right. Carry on.
Okay.
Next. What about in ERCP?
ERCP is done only if we need if we need a biopsy, sir. If we get a histopathological, if it is a borderline resectable, or if stenting is needed, then we are using ERCP, sir.
Now in ERCP also you can get certain findings, is it? In periambulary carcinoma, you will get a typical finding in ERCP. What is that?
There will be obstruction, periambulary obstruction.
Periambulary, yes.
And
So the observers, Rajan sir is very particular about periambulary carcinoma, the fill-in defects like that. In periambulary ERCP fighting will be.
Yeah. What is that sign called? That's what Sir Rajan sir and Karthikeyan sir were expecting the answer from you.
I don't know. I don't know, sir.
Okay, in carcinoma, what is the double duct sign? Have you heard of double duct sign?
Yes, sir. Double because of the dilatation of the pancreatic duct and the bile duct.
Cat size sign.
That I don't know, sir.
There are in stones, you get a cat size sign, double duct sign, a regular fill-in defect in periambulary.
Periambulary.
Yes.
Saiga,
Okay.
in the CT, what are things you specifically look for in the CT? What are things you look in the CT? The MD is multi-detector CT usually. What are things you look in the CT? Specifically look for in a case of carcinoma or periambulary carcinoma?
Sir, we have to look for the infiltration to the major vessels, especially, sir. We are planning a surgery.
What are the name the major vessel? Name, please. Name
portal vein,
Okay.
superior mesenteric vein, superior mesenteric artery, and the hepatic artery, and gastroduodenal artery, celiac axis.
Yes. What are other things you look? One is vessels.
Then the presence of lymph nodes, sir, metastasis, and the duct dilatation, sir.
After the CT, how would you classify these sort of patients? How your patient? How you with the CT? How do you classify?
Can be classified to completely resectable lesion, and borderline resectable, and unresectable lesions, sir.
What are the absolute contraindication for resection? Absolute contraindication.
There is peritoneal metastasis, then multiple metastasis.
Extra pancreatic disease. You can put it as extra pancreatic disease. Absolute contraindication. Then other.
What is the ideal way to find out the extra peritoneal mets, Sneha? You evaluated patient well with the all imaging. None of the images say that is peritoneal mets. Still, you suspect that peritoneal mets because that makes a lot of difference because you don't operate if it is so, and otherwise it looks like operability. So you need to know that it is you are right in opening or not. How will make it?
Laparoscopy, sir.
Laparoscopy. You have to do laparoscopy, and then later you can convert and open and go ahead with that.
Okay, sir.
So if it is operable, sir, we'll go for treatment, sir.
One more thing. What are other contraindications? One is he mentioned that is the involvement of vessels and extra other CT findings say it is a contraindicated. The resection is contraindicated.
There is multiple mets, liver mets.
This is not operable with the CT. With the CT, how can you say this is
multiple liver mets?
CT findings. That is I mentioned extra pancreatic disease. Okay, one.
Then there is more than 180-degree abutment of the SMA, sir. SMV-PV involvement and
SMV involvement. SMA involvement.
SMA.
These are absolute contraindication for resection. With the CT, you can assess by classified or resectable, borderline resectable, unresectable. Only palliation is possible. These three types of patients have in your after the investigation. If you are able to say this patient belongs to which group after your CT and ultrasound, CT or laparoscopy. Yes.
One more thing, Gobi, that size of the tumor also, if it is less than 4 centimeters, it is resectable.
It is a 3 centimeter, I think, right? Less than 3 or 4 like that. Size is very important, especially carcinoma head of the pancreas. Size is important.
It is more than 3 centimeter.
3 centimeter, more than 3 centimeter.
Vishwanathan and Dr. Vishwanathan.
Everything is mentioned now, I think, and again, Rajan sir has got made a comment. Which that is my question is not correctly answered by her. That is first comment. That is contrast. What is the contrast in MRCP? That was my question. And sir
MRCP,
want a
there is
specific answer.
there is no contrast used, sir. Bile itself will act as a.
Yes, that is the answer.
Bile is the contrast.
Yes,
But
that is the answer we want. Bile is the contrast.
that's the answer later in the session.
Non-contrast, yeah. Bile is the contrast. Is it true?
Yes.
Right.
Okay, so your investigation that you will rely upon is your CT scan.
Okay, sir.
That is the standard for evaluating a pancreatic carcinoma, right?
Okay, sir. Yes, sir.
Okay, then what is the situation where you will do MRCP with obstructive jaundice? CT is, of course, the most sensitive and the standard. And what protocol will you use for doing for in a pancreatic carcinoma?
Pancreatic protocol, sir. Triple
Okay,
phase
what do you
CT.
mean by that?
That is a triple phase CT.
Yeah.
The slice 3 mm slices are taken. Then the triple phase means arterial phase and pancreatic parenchymal phase and portal venous phase.
Involvement of portal vein is an absolute contraindication for surgery?
No, sir. If it is resectable and reconstructable, it is not a absolute contraindication.
Okay, which vessel is absolute contraindication for surgery and to what extent?
Celiac axis.
Sir, absolutely we discussed. Going to further
No, but that wasn't clear actually. I think either because of the audio or because we didn't get a clear answer. That's why I was asking again.
If there is more than 180-degree abutment of the superior mesenteric artery, then it is a contraindication, sir. Or if the lesion is involving gastroduodenal artery up to common hepatic artery, then it is also a contraindication.
There is lymph node. Is it a contraindication? Around the tumor, there is a lymph node. Is it a contraindication?
This is not a contraindication, sir.
Okay, correct.
It is very common lymph nodes getting enlarged by reactive hyperplasia in carcinoma pancreas. Large lymph nodes may be there. Finally, biopsy report comes as a reactive. No malignant cell 3.
Sneha, I want to ask one question. If there is no gallbladder, what are other possibilities? In the case you got a gallbladder, that is why you are mentioned periambulary and pedopancreas. With no gallbladder, then what else?
No gallbladder may be due to hilar cholangiocarcinoma, sir. We won't get it. Then if
What
the
is
gallbladder,
what is the commonest cholangiocarcinoma?
it's hilar, sir.
What is the other name for
Klatskin tumor. Klatskin tumor.
In that case, what English will do? They are suspecting a Klatskin proximal lesion. What English?
What investigation, sir? You mean? MRI, MRCP, sir.
Proximally MRCP, distally CT, and MRCP that the lesion is there, Klatskin tumor is there. How will you confirm your diagnosis? There's a Klatskin tumor or a cholangiocarcinoma. How will you confirm your diagnosis?
By ERCP, sir.
Tumor is the passing high, not the lower range.
Endoscopic ultrasound.
How will you get the tissue diagnosis?
Tissue diagnosis by either by endoscopic ultrasound FNA or by ERCP brushing.
No, ERCP not possible. The tumor is high.
USFNA, sir.
US not the answer.
Then percutaneously with a CT guider.
Yes, correct. PTC. What are the? How will you send the patient for PTC? What are the precautions you will take? You are send the patient for radiology. What? How will you work up for the patient for a PTC? The jaundice patient. So how will you work up? How will you send the patient to radiology for PTC?
The coagulability factor should be corrected, sir.
That should be
by vitamin K.
should be normal, and proton time should be normal. And yes, mentioned coagulation corrected. Blood should be ready. Then how will you tell me the procedure? How will you they do the PTC? What is the procedure?
What is the specialty of that needle? What is the needle used for PTC? What is the name of the needle, Sneha?
I don't know, sir.
It's a Sheba needle or Okuda needle. Sheba is the university, Okuda is the person's name. And very lengthy, fine needle. It is blunt needle. It's not like needle like a usual needle, like a sharp. There is no bevel in the needle. And very flexible needle. Now, reason why it is so flexible and blunt is it can be negotiated with the biliary radical easily, and so that it will not perforate the wall of the biliary radical inadvertently. There's a reason it's a blunt needle. Okay. There is Sheba needle or otherwise called the Okuda needle. Okuda is the person's name. Sheba is the university. Okay.
Okay, sir.
She didn't answer. How will you get the biopsy? Cholangiocarcinoma. Asking.
Under
ETC attendant, you can drain the bile obstruct, and I will take the biopsy.
cytology, sir.
How will you take this PTC?
How will you reach the tumor? In a periampullary, you can do endoscopy and take biopsy. In carcinoma head of the pancreas, you can do endosonography and take a
Theram, sir, you can answer. You can answer, sir. I think
you can
not
take, do an FNAC and take the biopsy. And in proximal growths, there is an entity called through ERCP baby endoscopy is there. You can go through the baby endoscope and take a brush biopsy from that. If it's a CAT scan tumor, whatever it is, that is the only way to do that. And it is this definitely endosonography is very, very useful. They will be able to get a needle aspiration without any problem. If endoscopist, they do now currently endosonography very easily, very perfectly actually. It's a very, very, very good investigation to get a biopsy. In a periampular, of course, endoscope, you can see the growth there, you can take a biopsy directly, provided program time is made normal by either 3 points of FFP or vitamin K 10 milligram, currently intravenously available once a day for 5 days. Before doing, always confirm that PT and repeat it, and they say that it is normal. Then only you go and get a biopsy done, whatever type you want. Okay. So how will treat, sir? We'll go for treatment, sir.
Yes, sir. You got it.
You said it's the periampullary. You stick out to the periampullary first. Then we may possibly have a small discussion about other types, which Professor Gopi sir has already discussed, or what are the differential diagnosis. Stick on to your first diagnosis and tell it is operable. Whatever he has told, or resectable, border resectable, unresectable. We say it is a resectable periampullary carcinoma as per your clinical diagnosis or final diagnosis. How will treat? I will prepare the patient for surgery, and what surgery you will do. I will do the surgery briefly. You tell.
First, the anemia should be, the hydration status of the patient should be corrected. Then correction of anemia, and the albumin should be corrected. Then coagulation should be corrected.
How will you correct the coagulation?
By giving injection vitamin K, sir, 10 milligram for 5 days, or by giving FFP, sir.
Okay.
But okay, right. Hydration is very, very important. Dextrose is very, very important. Glycogen store reserve should be maintained. In a critical liver, glycogen storage is very, very important when you operate. That is the one which makes up your postoperative easy outcome. So you have to give the dextrose, maybe 10% like that. And role of albumin is a controversial, whether it really helps by preoperative albumin. I don't know, sir has to tell. Karthikeyan sir, Dan Babu sir is there. They should tell, because people use it, but how far it is useful, maybe useful post-operatively. Pre-operative preparation, role of albumin is a controversial, but glucose, hydration is very, very important, and vitamin K, FFP if needed, and mannitol is again, some people you don't use it, still we use it just before surgery will start, and then we'll go on to give another 3 to 5 days eventually to increase what you said, hepatorenal syndrome, to prevent that. So flush the kidney as much as possible. So these are things, of course, antibiotic is this one controversy, but there is a chance that associated cholangitis, even though that not that common, unlike in the CBD stone, cholangitis associated with the malignancy, you have got a high risk, and the mortality will be very high if you operate. And if it is so, if you think that there is suspicion of cholangitis, better to start IV antibiotics and go ahead with the surgery. That is the requirement. So that is the preparation. Once you are prepared, now tell briefly surgical step.
No, she has not mentioned about biopsy. In a periambular culture, which is very important.
Yes, sir. Biopsy, she told, sir. Endoscopic biopsy, we have discussed that.
Endoscopy only, she said. Biopsy?
Endoscopic biopsy, we have discussed that. Endoscopic biopsy, we have discussed the baby endoscope. We have looked endosonographic biopsy, we have discussed that.
I discuss.
And also, if the patient is having very high bilirubin, can you reduce it preoperatively?
Yeah, what is the role of stenting in a patient with the, usually there is no role. What is the role? When you will say that you have to do the, bring down the bilirubin before you operate, in an operable case?
Sir,
And how you will bring down?
If there is intractable pruritus, and if we are expecting a delay from the diagnosis to the surgery, like deranged coagulation or malnutrition, to correct that, we have to stent the patient with ERCP.
What is the bilirubin level which wants you to do a stenting or drainage of the bile? Which bilirubin sensor you should drain it?
It is better to come bring it down to less than 10, sir.
Okay. Vasu sir, you have to.
Can you mention one complication? Yes, the important complication.
The perforation and bleeding can occur, sir. And infection, sir. Cholangitis.
What infection?
Cholangitis and liver abscess can.
Procedure pancreatitis.
Pancreatitis.
Pancreatitis. ERCP-induced pancreatitis. That is a very important complication of ERCP. So it should be done under cover of antibiotics. Okay. So you are now everything is okay. English is okay. As sir mentioned, tell the steps of Whipple procedure. You are planning to do Whipple? Am I correct?
Yes.
What are the structures you are moving? Otherwise,
Whipple's steps. You want to describe the steps, sir?
Steps, briefly tell the steps now.
quickly.
Patient should be in supine position. Initially, we can do a diagnostic lab to rule out the metastasis.
Okay.
And after opening the abdomen, look peritoneum and liver surface, inspect for the metastasis. Then cattle brush procedure to bring down the hepatic flexure medially, and cauterization of duodenum. Expose the
that cauterization loaded. What at that step? What are the things you will palpate?
What is extended cauterization, Neha?
Till the left to aorta is exposed, sir, left border of aorta.
Usually, your initial dissection is anti-clockwise, anastomosis is clockwise. That is what is being remembered. Castlebat, the mobilization, then cauterization, then CBD isolation, then portal vein identification, then gastroduodenal artery dissection with the hepatic artery also you have to dissect. Then below, of course, that is again controversy. Now, till it is available practice by general surgeon, put your finger below, one finger below, one finger above, in front of the portal vein, supine vesical vein becoming portal vein, under the neck of the pancreas. Now, under the neck, just exactly in front, anterior part of the portal vein, there is no blood vessels, connecting blood vessels. Laterally, there is. Your finger should be absolutely in front. If you deviate your finger, oozing will be there, because venules in the superior vesical vein are very friable. Unlike veins joining the portal vein, they are not friable. But veins joining the superior vesical are very, very friable. Even just blunt dissection will cause torrential bleeding. But if you keep your finger exactly in front, behind the neck, bleeding chances are very less. And you oppose your finger from above and below by both index finger, right and left. Once it is so, you are through with your resection. That's what we presume. Then after that, isolate the CBD, remove the gallbladder. It's absolute need. Always you have to remove the gallbladder along with the Whipples. Then, of course, identify this common, gastroduodenal clearly. Make sure that you are not dissecting the common hepatic artery, and also make sure that anomaly hepatic artery is very, very common. Sometimes it arises from the superior mesenteric artery also. So all those anomalies you have to keep in mind. Any suspicious, dissect the tree properly. That is important. Instead of avoiding dissecting, dissect the tree properly. Make sure that things are normal, and make sure that blood supply, arterial blood supply, is very, very essential for the compromised liver. Even though it's only 50% of blood supply, oxygenation, main oxygenation of the liver to the liver comes from the hepatic artery. So hepatic artery, not to injure hepatic artery, not to ligate inadvertently, thinking that the gastroduodenal artery is very, very important. To dissection is absolute need. Once you have done that, if you go meticulously, step by step, anti-clockwise, usually bleeding is not much. Your bleeding comes only when you remove the pancreas from the portal vein, last step. And after that, of course, go to the duodenojejunal junction, isolate the junction segment, then put a stapler or suturing, whatever that facility is available in your hospital. Then railroad it under the superior mesenteric towards the right side. Then separate it from the posterior aspect. That is the stepwise. So anti-clockwise dissection, clockwise. Then of course anastomosis. Dissection is the most important thing. 1, 2, 3, 4, 5, 6. Anti-clockwise. That is the method you have to use. If you use this method, it should be absolutely clear. Only thing is initial identification of superior mesenteric vein below after the mobilization of the hepatic pressure and colon. There will be usually until you identify the superior mesenteric vein will be stressed, you will create some bleeding because very friable tissues there around the superior mesenteric vein. Veins are very, very friable there. Not so in the portal vein. When the dissection upper part, there's a clear luciferial tissue and plane between the CBD and the portal vein. Nice, slow, meticulous, long curved artery, curved right angle forceps, not small right angle, long, you got a long curved artery forceps are available with a smooth tip actually. With that, you decide that one by holding the CBD with the onto the forceps, you get a very good plane. That's a very clear plane where it's a very clear loose tissue without any problem. We are unlikely to injure portal vein there. Our worry is always injury in the lower part, where superior mesenteric vein, where viable. Once you get that, you isolate, you can cut and clip or clamp the common bile. There's a controversy about that, whether you clamp it or release it. Few say that release and keep it open so that bile drains out, so that biliary load is reduced. You are allowing the liver to breathe because bile comes out. There is one more thing you have to observe is what bile comes. If the normal bile comes or white bile comes. If it is white bile comes, liver is still is gone for a real critical stage of functioning. You heard about white bile, Sneha?
Yes,
What
yes,
is
sir.
white bile?
Actually, it is a misnomer. It is a mucus secretion because of the obstruction, sir.
Okay, it is neither white nor bile. It is opalescent. It is mucus. It is secreted
No,
from the lining of the biliary tree. That is called white bile. It's on-table finding, and this says that liver function is real critical. And in these patients, the outcome, they go for postoperative problems. So you have to anticipate problems and manage accordingly with a proper ICU care. That is the requirement. That is the finding of. That is the reason why white bile is important as far as your management is concerned in postoperatively. Okay. Then you do the anastomosis in the clockwise direction. You remove everything, observe everything, check the BP, central line anyway is there, speak to the anesthetist, relax for a while, then confirm that BP, everything is okay, especially arterial blood pressure. Then see for oozing anything. Before anastomosis, make sure of the absolute hemostasis. After anastomosis, you can't see anything, then you will really be in trouble. Make sure that 100% hemostasis is there before starting anastomosis. Once you've done that, start the anastomosis in the clockwise direction. First to do the pancreaticojejunostomy, then do the hepaticojejunostomy, then do the gastrojejunostomy, because end comes there. Okay. So that is the sir.
And you nicely elaborately describe the surgery. Thank you, sir.
Just wanted to explain the technique, anti-clockwise, clockwise anastomosis. Now there is a lot of methods available for pancreaticojejunostomy. You can dunk when you cut the neck of the pancreas, make sure that where is the duct. Now order is usually duct is front, next is vein, next is artery in the splenic level in the body if you say, and duct you find out and see always what is the duct size is important. If it is wide duct, you should be happy that you can do a duct mucous anastomosis. If it's small duct, it's very difficult to do that. Then you can dunk it and suture it to the 2-layer. Always suturing is with the polypropylene. Never use vicryl. It is dangerous because disruption, pancreatic juice are really disruptive. It digests everything it come across. Really dangerous. Pancreatic juice, so much digestive content it contains in the body. It digests everything. It is only safe for suture material is the polypropylene 30. You can do it in a 2-layer, and you can deeper layer can put interrupted, and further layer anterior second layer could be continuous. You should be happy that deep patient. Many times this patient may be some element of a chronic pancreatitis. If it is so, you should be happy that, because if there is a chronic pancreatitis, your sutures take up well. If it is normal pancreas is so soft that your bite will not take up. So there is if the stiff pancreas, your bite will be very good and your holding will be good. Most of the time, what we are worried post-operatively, the disruption of the pancreas, anastomosis, that almost always it is a mortality to the patient. You are not bothered with hepatic, don't disrupt, because of wide lumen, it is unlikely to disrupt. Even 1 layer, anterior layer, usually when you do hepatic anastomy, traditionally if it is 6 mm or 8 mm CBD, 2 plus 2, 2 anteriorly, 2 posteriorly sufficient. But a wide lumen dilated CBD like this, you can put a 330 vicryl or 3 front and through front. Of course, traditionally PDS you can use. In our setup, 30 vicryl is sufficient. Always interrupted. Ideally, knot should be outside. That is a controversy. But if possible, in a wide lumen, you can always put your knot outside. Interrupted, outside knot, 3 posteriorly, 3 anteriorly. Always put the sutures first, then put the knot. Otherwise, you can't railroad. You can push you can't push the jejunum into the CBD, into the hepatic system, common hepatic duct. Okay, then put the anterior bites and put the knot. Usually, take a wide lumen, it takes up very well. You won't be worried at all about that. There is no need to stent at all. The current evidence says that there is no need to stent the common bile duct. Now, what is worried is always pancreatic jejunostomy as far as your immediate outcome is considered. Then, of course, do the GJ. Sir.
Yes, sir. Sneha, if you can anastomose the jejunum, any other structure you can anastomose pancreas other than jejunum? One you can use jejunum, pancreatic jejunostomy. Any other?
Gastro to the stomach, sir.
Any modification? Correct. Any modification of the people surgery? What is that? Any modification?
Pylorus preserving procedure, sir.
Pylorus PPPD. What's the contraindication for pylorus pancreas? Contraindication?
There is invasion, duodenal invasion.
Invasion up to the duodenum. And the second point, positive lymph node around the duodenum. What do you mean by retroperitoneal margin or SMA margin? What is SMA margin or retroperitoneal margin? What is that margin? What is the significance? Uncinate margin, retroperitoneal margin, SMA margins. What is the significance? What is the importance of that margin? You can answer, or I will answer. This is an important margin, SMA margin, that you should setting the specimen with the ink, methylene blue. There's a maximum chance of recurrence. That is known as SMA margin or uncinate margin or retoma. That is the importance of this margin. I think it is time for wind up the session. Other examiners, we'll go to quickly go to the Vassar and Kapten sir and Isnathan. Hello.
Yeah, no, just to go through the other, as we said earlier, we have already completed the periumbilic carcinoma. Just to mention about shortly about the other diagnosis.
Head of pancreas.
Yes.
We had one differential diagnosis of head of pancreas. So,
yes, sir.
Okay, what are the signs of inoperability in head of pancreas lesions?
Head of
I think we'll already discuss that one.
Was it discussed?
Discuss. You can ask some other
Yes, sir. It is discussed in detail, sir. Gopi sir has discussed in detail signs of inoperability, everything. Let us tell the treatment for
only the treatment part. Okay. So is there any difference between the treatment of head of pancreas and periampullary? I don't think. Basically, I think it
There
all
is no difference. The
rests
only
around
thing
the
is,
same thing.
periampullary is easy, technically easier. Head of the pancreas will be technically little difficult.
Technically difficult because
It's the only
the
difference.
dissection may be.
Now there is few word about the pancreatic gastrostomy. What is the role of pancreatic gastrostomy, Sneha? PG, there is a last maybe 10 years back, there was a lot of evidence has come for about the pancreatic PJ and PG. That's what is being called as pancreatic gastrostomy and pancreatic jejunostomy. Even that point of view, we also used to do few pancreatic gastrostomies. What is the idea of doing pancreatic gastrostomy?
I think, sir, you can answer, sir.
It's a technically the posterior surface of the stomach. It's a dunking there. It's technically easier. Now, only problem is because acid is there, pancreatic juice getting neutralized. So only idea of doing pancreatic gastrostomy is safety. Second thing is endocrine function is still retained. So what we are mainly in such a situation is concerned about the endocrine function retaining. We are not at all will be able to get back the exocrine function if you do the pancreatic gastrostomy, because acid neutralizes completely neutralizes the exocrine secretion of the gland. So it is endocrine function which will be sustained.
Okay. Sneha, I want to ask, if it is inoperable, how will you manage? Is it inoperable? It is a fixed SMA or a portal vein. How will you manage? Inoperable case what palliation?
For the obstructive jaundice, sir, we can either stent it, ERCP stenting,
What's the
or hepatico-jejunostomy by triple bypass can be done, sir.
It's a inoperable, you will hepatico-jejunostomy. Gallbladder is there. How will you palliate the jaundice? You mentioned gallbladder is there. Distended gallbladder. So what palliation?
You said triple anastomosis. Describe
Triple
it.
anastomosis.
What is it?
Triple means you mention, please quickly mention triple anastomosis.
Sir, hepatico-jejunostomy, gastro-jejunostomy, and jejuno-jejunostomy.
Not hepatico-jejunostomy, inoperable case.
Choledocho-jejunostomy.
Gallbladder is there. So what is the simple procedure you will do?
Cholecysto-jejunostomy can be done.
For gastric outlet?
Gastro-jejunostomy.
Any other palliation?
Sir,
So
sorry, sir.
Metallic stent.
Sir, sorry to disturb, sir. Sir, in the exam, if they say cholecysto-jejunostomy may not be accepted, sir, because there is a chance that once you drain that, cystic duct may get blocked. If it is so, your entire exercise will be waste. So, exam-wise, I think choledocho-jejunostomy will be the correct RUNY. For their purpose, students' purpose, choledocho-jejunostomy will be the ideal answer rather than cholecysto-jejunostomy. Even though we practice more often because easier it is.
And life expectancy is small,
Yes,
and already you can take college.
Yes, sir. That's sufficient. It's actually sufficient. But in the exam, they will be drilled whether it is so or no. Thing they'll be in confusion.
So there are three palliation: palliation for jaundice, palliation for obstruction, palliation for pain. These
Yes,
are three palliation for
periampullary,
severe head of band. For pain, you know, we are not discussing the palliation. You know everything what pain manage. These are the palliations. I think the time for wind up the section is over. So, Karthik sir, you add one thing?
Sir, Karthikeyan sir, just conclusion, sir.
Conclusion discussion, because you have Dr. Sarbi has explained the Whipple's process in a way that Sneha is not going to do Whipple's for another 5 years. Only after assisting a good surgeon she will do the Whipple's.
They have to assist many cases before doing, sir.
Okay, thank you. Right.
Thank you, sir. Thank you, everybody. Thank you, Sneha. You have presented very well. You have discussed very knowledge is good. No issue in that. Good it is. Initially, there was some problem with the internet connection from you. Otherwise, you presented well with the good presentation, actually. And thank you, Rajan, sir, very much. Thank you, Fazil, sir, Dayanand, sir, Vishwanath, sir, Vasu, sir, Karthikeyan, sir, Gopi, sir. You are the master of everything. Good organizer by you, sir. Thank you.
Faisal Markaz, sir, is there. Sir, anytime Faisal Markaz, sir. Dr. Faisal Markaz, sir.
Faisal, sir, I told Fazil, sir. Thank you, sir.
Faisal, sir. Faisal, sir.
Can you hear me now?
Yes, sir, we
yes,
can
sir.
hear you, sir.
Yes.
Yeah, I don't know what my role is.
Yes, sir. You're audible and visible. No, it is not.
Audible. Muted.
Sir, now not audible.
I had some
Now it's okay, sir.
problem with my audio.
Now it is okay. Now it is okay. Fine.
Okay, about Sneha, one Vasu was already told, English grammar is very poor. You cannot incorporate present tense and past tense, which Masu also missed.
Yes, sir. That is truly
Stop
right.
and comma are very, very important.
Yes, sir.
If you go back to your slides, you will understand. You go through everything and find out at least about 50 spelling mistakes are there. No, rather, grammatical errors are there.
Absolutely, absolutely.
Okay, presentation is fairly all right. But you need to make more presentations to make yourself comfortable with the examiners. I think you are 80% to the mark of going for the examination. You have to improve a little more.
Yes, sir.
That's about you. About the examiners, I'm not very happy because the postgraduate student is completely disorganized by the higher level, which I think in a postgraduate MS examination, we need not go into this much of details as particularly Dr. Bhatt told.
So that is for learning purpose, sir.
In a session like this, it is all right. But as far as an examination is concerned, the candidate will be completely lost. She was 80% lost.
But she was answering, sir, all those. Only thing clinical point, later she was picking up the thing. That's why I went on telling.
It is okay. When it comes to actual examination,
yes, sir. Actual examination, if she reaches Vipul's level, like Vasu sir asked, what are the SMA, all those things. If you reaches that level, that means it's
too much.
That
is too much. Sneha.
For them, it is too much. Sure.
Okay, it is a friendly conversation.
No,
so
no, sir. Very well accepted. No, definitely sure, sir. Very well accepted. Very nice, sir.
But I missed two things. Karthikeyan is, of course, nearing my level of seniority. So he talked about barium meal and all. But two things were not mentioned. One is Charcot's triad and Kurzweil's law. Could you tell both these when you come to obstructive jaundice?
Charcot status, there will be intermittent jaundice, intermittent fever, and abdominal pain.
Yeah, probably you could mention about this somewhere to say that it is not.
Yes, sir.
Then one more thing in the diagnosis. If I were an examiner, I will ask you for one diagnosis rather than 3 diagnoses. And why put in an uncommon diagnosis of a cholangio? The last one you said is fairly uncommon. Have you seen any cholangiocarcinoma below the common bile duct? Have you in your training seen any cholangiocarcinoma below the common bile duct? So I don't think a postgraduate student should make a diagnosis of a thing which you have not seen. If the examiner is asking what else, or you could at least say put a differential diagnosis. When a candidate is presenting in an examination, we would require single diagnosis and proceed in that direction. Okay, thank you. It's a wonderful effort by Gopi to organize all these things. I find 69 people were there, and I think it will be a very good session for everybody. But Sneha, you should present at least 10 cases like this in front of somebody, peers or teachers. You will pass the examination at the first attempt.
Sir, yeah. Sir, before concluding, hello, sir. Can you hear me?
Yes.
Hello?
Yes, sir.
Sir, there is a relation between Moynihan, Lord Moynihan and First America, sir. He was the first chairman of editor of British Journal of Surgery. Today I came to know. And you are and he continued the position till his end. I think you are also all and everything of the Kerala Surgical Journal. You are continuing the same. But so today I read that this Lord Moynihan, the first editor-in-chief, and you are also continuing like this.
Okay,
Thank you,
please.
sir.
I ask everybody to submit papers. We are getting ready with the next edition, next volume of the journal.
Thank you, sir, for your comments. Now we'll go to our evaluators, answer and the hand above, sir. Please, sir.
Let Babu sir start today.
Okay. There is a famous quotation by William Osler. Jaundice is the disease that your friends diagnose. Now, I will give 10 commandments for obstructive jaundice. Every time I am just facetly telling. 1, clinically detected when the level is more than 2.5. Even though the normal level is given, usually clinical detection is when the level goes beyond 2.5. And normally the conjugated bilirubin is less than 5%. When the conjugated goes above 50%, suspect obstructive jaundice. In hepatic causes, 85% are unconjugated. So these figures, I think, is important. The third thing is, you are discussing obstructive jaundice, you should also remember that there are benign causes. So its classification is, it may be benign or malignant. The malignant causes, you have got periampullary, head proper, then the cholangiocarcinoma, and the Klatskin tumor. So this is how you classify obstructive jaundice. Now coming to the risk factors, it was not discussed. Smoking, chronic pancreatitis, obesity, or new onset of diabetes, all those things are risk factors. And there are some hereditary risk factors like familial atypical mole, multiple myeloma syndrome, hereditary breast and ovarian cancer syndrome, and Lynch syndrome. Actually, she was talking about the family history and all. Now, the fifth is Benjamin classification is a good clinical classification for obstructive jaundice. The Benjamin type 1 is there is complete obstruction. Type 2 is intermittent obstruction. Type 3 is incomplete chronic obstruction. That is type 3. And type 4 is segmental obstruction. So Benjamin classification, you should remember. Then the sixth is, you should mention pancreatic protocol triple phase MDCT. That should be your answer. Pancreatic protocol triple phase MDCT with 3 mm slices. The next one is for upper end of the biliary system, MRI is the investigation of choice. For the lower end, CT is the investigation of choice. And next one is endosono for arterial encasement and biopsy. For biopsy also, usually we don't need a biopsy, but inoperable cases before going for chemo or palliative treatment, especially the oncologist will ask for biopsy. So for that, the ideal is endosono guided biopsy. Then, of course, the 3 categories: resectable, borderline resectable, and unresectable. And then coming to the definition, that is the last thing which I want. What is head? What is body? What is tail? This you should know. Head is, by definition, a tumor which is right of the superior mesenteric vein portal vein confluence. That is the head. Body is left border of superior mesenteric vein and left border of aorta, in between left border of superior mesenteric vein and left border of aorta. That is the body. And beyond left border of the aorta is tail. So I think you should know what is head, what is body, what is tail. So this is my 10 commandments for obstructive jaundice. Thank you very much. Now Rajan sir will give further comments.
Well, sir.
organizing such a wonderful clinical symposium. Thank you, SRB, and all the examiners. Neha, isn't it? Neha or Sneha. You have done reasonable justice, but I am sure there had been few hiccups, as everybody has pointed out. Now, obstructive jaundice is a situation where there is arithmetical analysis and algorithmic approach you can always follow. The simple process is that you suspect obstructive jaundice clinically, is confirmed by labs. Things had been already told. Now, the second aspect is to establish the site of obstruction, which you can do clinically, where the Corvius law, etc., comes in play. At the same time, by imaging. The role of imaging has been well discussed. And type, nature of the block. The nature of the block, well, in a periampullary, you can easily identify by a side viewing endoscope. But in other situations, as particularly Dan Babu has said, that when it is inoperable, well, the oncologist might ask, you may go for an endoscopic ultrasound or other methods to get a biopsy specimen. But I think an endosono and a fine needle aspiration will settle the issue if the oncologist will ask for. Now, regarding the symptomatology, you should always ask for obstructive jaundice can present with pain, or it could be painless jaundice. It could be pyrexial, it could be non-pyrexial. It could be pruritic, it could be non-pruritic. It could have pale stools, not only pale stools, but the pancreatic head is totally blocked. You will have exocrine insufficiency, which will cause the feces to be frothy, floating, foul smelling. In fact, that is part of the enzyme deficiency. Now, there could be bleeding tendency which may present as petechiae. So it could be a petechial presence in situations of jaundice. Now, as far as the management is concerned, yes, once you have imaged, once you have diagnosed, you classify it to operable, borderline resectability, or totally inoperable. We have discussed it in detail, and SRB has discussed the Whipple's procedure extremely very well, so that you just have to go and do it. That's the sort of thing. Now, in managing, you should understand that you should optimize the patient to undergo a surgery. If the patient is planned for a major surgery, it's a very major surgery. It has got blood loss. It has got a lot of complications, bile leak, bleeding, gastroparesis. Many things had not been discussed in the process. So, as far as the operative procedure is concerned, I would request most of the starting surgeons to train with operating magnifying loops. Small pancreatic anastomosis could be wonderfully done. So also, not a marginally dilated biliary duct also. You should start training with using magnifying loops. I'll ask one question to Dr. Sneha. The Whipple's operation was done by A.O. Whipple. Can you elaborate who is A.O. Whipple? Sneha has gone. Hello.
Sneha.
Sneha is there.
Sneha.
My question is the complete name is A.O. Whipple.
I don't know.
Sneha is not there.
Sneha is not. Maybe old father Vipul, sir.
It's Alan Old Father Whipple.
Old father Vipul, sir. He is. He is the two-stage procedure. First.
Yeah. Now, before Whipple started, people were doing with absorbable sutures for anastomosis. You rightly said about the use of non-absorbable anastomosis so as to prevent anastomotic leaks, right? So many people do continuous suturing. Rajan Saxena in SDBGI is a proponent of continuous suturing of the bile duct. He was talking that in one of the discussions.
Yes, sir.
Yes, people vary. There are about 80 methods of reconstitution after the pancreatic duodenectomy. If you read the Payne's pancreatic surgery manual, you will find that there are about 80 methods after resection. So it was a wonderful meeting. Thank you very much, Gopi. Thank you, all the panelists.
Thank you, sir. Thank you, sir.
Yeah. Thank you, Dan, sir. At the end of the session, the senior people are waiting for your comments. The two people, Dan sir and Dan sir comments, they are enjoying. I got the message. And this time we got another great person, that's Russell Marker, sir. And for Benjamin classification, I say the answer book first given nicely on the Benjamin classification. Students can read that first. And others, today we got the great examiners like SRB sir from the Karnataka. He's thank you very much for spending our time with us. Another is Karthik sir, one of the senior most professor in Kerala. Thank you, sir. Then Ross sir and Dr. Dr. Vishwanath from Trivandrum. I am happy to hear you and say nice words and also advise the students regarding the obstructive jaundice. One announcement before concluding. Hereafter, we will have the sessions 8 p.m. on Saturdays. Next week, Saturday, 8 p.m. so that others can attend other programs, especially the program going on by this and other topics. So we can enjoy that also. So it won't disturb, it won't collision, there won't be any collision between these two topics. So that is the announcement. So students, please. And next cases will present by the PG from Kottayam about the right ilia for summas. Right ilia for Kottayam PGs will present Saturday 8 p.m. Once more, thank you very much to all seniors and all the examiners and students. And Dancer, want to say something, Dancer?
Yeah. Before signing off,
Dancer?
One question to Sneha, just before signing off. Can I ask her one question? Just historical. Sneha, are you there?
Audio is some problem, sir. Your audio.
Sneha, are you there? Can you hear me now?
Ask the question, no problem, sir.
No problem, okay. Now, I just want to ask her what's the name of the prothrombin test? Now, not audible. Am I audible?
Hello.
Yes, now audible, sir.
You are audible, sir. We are thinking answer, sir.
Yeah.
You only better to answer, sir.
It's quick prothrombin time.
Which one, sir?
Hello.
Quick, QUIC, quick prothrombin time.
Okay, sir. Okay, sir.
It's interesting because till the time that quick prothrombin time was identified, people used to die of bleeding, coagulopathy.
Okay, sir.
So the vitamin K brought out a radical change in the prognosis and operability and success of pancreatic duodenectomy. Thank you very much.
Thank you, sir. Good information. Thank you, sir. Thank you, everybody, sir. We'll wind up, sir. Thank you, sir. Thank you, sir. Thank you.